Welcome to segment 46 of the Falcon Online Anatomy Review. This time we're going to be discussing the head and neck developmental issues. We'll start with the pharyngeal apparatus. The pharyngeal apparatus has 5 pharyngeal arches and 4 pharyngeal pouches. Even though they're numbered 1 through 6, only 5 of them actually will develop. Likewise, there are 4 pharyngeal grooves interspersed between the pouches. The pharyngeal membranes will run between the pouches and grooves and will connect at the same levels as they go on the outside and the inside of those pharyngeal arches. The components of the pharyngeal arch will contain a core of mesenchyme, which will largely be neural crest in origin. They'll be covered externally by ectoderm and internally by endoderm. Inside, each of those will develop into a pharyngeal cartilage, an associated pharyngeal nerve, and an associated pharyngeal vessel, which will be one of the arches of the aorta. Let's start with a question to make the relevance of this area importantly known. A newborn male has a noticeably small mandible, and a CT scan and physical examination reveal hypoplasia of the mandible, a cleft palate, and a defect of the eye and ear. Abnormal development of which pharyngeal arch will most likely produce such symptoms? We'll see in a little bit, if you're not sure that this was a first arch syndrome, that there's a constellation of things that are first arch syndrome associated. So first arch syndromes will be something that's important to get a grip on as you start preparing for the USMLE test. Now let's look at the cartilages of the arches. The first arch is going to be Meckel's cartilage, and the second arch is going to have Reichert's cartilage. These are the most often tested ones. There's a third arch cartilage and a combined fourth and sixth arch cartilage as well. These are going to form the skeletal elements of the arches. In the inset, you can see at the fold right around the day 24 that there's going to be a nose and eye placode that are at the same plane as the orobucopharyngeal fascia, and that's going to be the stomodium or the primordial mouth. Those are just endoderm and ectoderm fused together without an interposed mesoderm. And the frontal nasal process is going to swing around and come in contact with the maxillary and mandibular components for facial formations. Right now, let's look at the skeletal elements that are produced from the arches. As far as the first arch, there's going to be the malleus, incus, and a couple ligaments, as well as the mandible itself. The third ossicle, the stapes, is going to be formed in the second arch, and then it's also going to take part in the lesser cornu of the hyoid and the styloid process, as well as the ligament, which can sometimes ossify. Then we have the third arch, which is going to be the greater horn of the hyoid and also the lower portion of the hyoid bone itself. And finally, you have the thyroid and cricoid cartilage coming from fourth and sixth arches. We have Meckel's cartilage giving rise to the incus, malleus, and mandible. We have the maxillary process, which is going to give rise to the maxilla zygomatic bones and temporal squamous bones, as well as the palatine bone. And second cartilage is going to give rise to the stapes, styloid process, and a couple of ligaments, and also to a portion of the hyoid. The third arch is going to give rise to a component of the hyoid as well, and the fourth and sixth arches will give rise to the laryngeal cartilage and the cricoid cartilage. What muscles are going to form in the arches is going to be the muscles of mastication, which are associated with the first arch, and there's going to be the mylohyoid and anterior belly digastric, as well as the tensor palatini and tensor tympani muscles. All of these are innervated by cranial nerve 5, which is why the nerve associated with the first arch is known as the trigeminal nerve, specifically the mandibular division. So the trigeminal arch is going to be cranial nerve 5, first arch. The second arch associates with the muscles of facial expression and therefore is associated with cranial nerve 7 as the facial arch. Third arch is going to be associated with the stylopharyngeus muscle, which is innervated by the glossopharyngeal nerve, and it's also called the ninth arch. And finally, the larynx and pharynx are innervated by the vagus nerve, and it's also known as the superior laryngeal arch. Now we have the sixth arch, which is going to be innervated by the recurrent branch of the vagus nerve, and that's known as the recurrent laryngeal arch, both of which are vagus. Here, as in the question that we saw early on, is a first arch syndrome. And you can see how there's a macrostomia, or a large mouth, and that's going to be a preauricular appendage or low-set ears, a defective cheek as a result of clefting that didn't resolve itself, and hypoplasia or small mandible. Usually these first arch syndromes result as a faulty migration of neural crest cells. Another type of first arch syndrome you can see here is Treacher-Collins syndrome, or sometimes called mandibulofacial dysostosis. And oftentimes this is failure of the neural crest cells. Therefore, what you're not going to have is you're not going to have the zygomatic bone. You're going to have ear deformities where there's no ear at all, or just a simple appendage hanging off with no canal or any ability to hear. And then you have macrostomia, which is a wide oral fissure in comparison to the size of the jaw, which would be microagnathia. Here we can see the tongue buds that are going to be forming on the inside of this arch structure, and then you can see the foramen cecum where the thyroid gland is going to migrate down from. The first arch is going to have two components to it, the mandibular and the maxillary component, and then the other arches, except for 5, will progress down from that. There's an important membrane that needs to come into play where you've got this internal pharyngeal endoderm on the inside and this external skin or ectoderm on the outside of these arches. There's going to be a central core of mesenchyme or mesoderm that will come in, and this will be arising from the adjoining somites as well as the somatic mesoderm. Let's try another question. A 2-month-old infant has a small pit on the anterior border of the sternocleidomastoid muscle with mucus dripping intermittently from its opening. The pit extended to the tonsillar sinus as a pharyngeal fistula. Which embryonic structure or structures is or are involved in this anomaly? We're looking for the persistence of the second pharyngeal pouch and the proximal part of the second pharyngeal groove. These should be obliterated, but they're not obliterated in this case, and what you end up with is a combination of a pharyngeal cleft of 2 that's persistent all the way into that little purple area, which is a pharyngeal pouch. And that little purple area is going to be where the pharyngeal tonsil will sit in the oral cavity, and any fluids that can leak through there will leak out into the neck area. Typically, areas 2 and 3 of the pharyngeal clefts gets obliterated during formation as the lateral walls of the neck overgrow each other and fuse. The more important of the pharyngeal pouches and pharyngeal clefts are going to be number 1, because those will form the external auditory canal and the internal auditory canal, or the eustachian tube. So there's going to be a small membrane, which would be the tympanic membrane, that would persist as a membrane between these two pouches and clefts. That tubotympanic recess will be an invagination from the inside, and the external auditory meatus will be an invagination from the outside. In the second crypt or pouch, you can see that the tonsillar sinus would be developing here, and if it obliterates the pharyngeal clefts on the lateral side, this should just be a small area for the palatine tonsil. Now, in the third pharyngeal pouch, the thymus and the inferior thyroids will develop. Now, the thymus is going to migrate down into the superior mediastinum, where we saw and talked about it in the thorax, and it drags down those inferior parathyroids. That can be a tested item in that the inferior parathyroids can be all over the place tracked with that thymus as it migrates. And even though they start superiorly, they will get dragged down to be inferior, which is why even though they're in the third arch, they are inferior parathyroids. The fourth arch has a parathyroid associated with it as well, but because it's anchored there and doesn't migrate as much, then it will be less associated with any loss of position in the adult form. There will also be the C cells of the thyroid, which will be coming from the ultimobranchial body, which is going to be neural crest cell derivatives coming from the fourth arch. Here's a graphic to show the thymus and the parathyroids and how they'll change positions relative to the superior and inferior parathyroids. The thymus in purple will start migrating down into the mediastinal regions, whereas the thyroid gland and the superior parathyroids will stay anchored around the developing trachea after that tracheoesophageal bud comes off and starts dividing. And after 6 weeks or so, you can see how they've migrated into their final position, with the thymus below the thyroid and the parathyroids being in their changed relative position. So here you can see in words what we've just talked about in graphic format. Looking at pouch derivatives, there's a couple summaries. The auditory tube of the middle ear and the mastoid air cells derives from pouch 1. The tonsillar sinus derives from pouch 2. The parathyroids derive from pouch 3 and 4, and the thymus will derive from pouch 3 as well. Finally, that ultimobranchial body in pouch 4 will also be C cell producing. Now we'll move on to the formation of the face. There are 3 key players that are crucial in the formation of the face itself: the frontonasal prominence, the maxillary prominence in green, and the mandibular prominence in blue. The yellow and green are actually 2 separate components of the pharyngeal arch 1. 24 days, the stomodium is starting to be anterior in location, and this is going to fold under as that frontonasal prominence is going to start to connect with the maxillary prominence and the medial nasal aperture. A little bit further along, you can start to see how the lateral and medial components of the nasal prominence are going to fuse together. So the 2 medials will fuse, and the medial component will come and fuse also with the maxillary prominence. As this continues forward, you can see that there's a potential groove site that will follow between the green and the yellow towards the eye, or the blue and the yellow towards the ear. And that's where you can get those first arch syndromes, where you can have a clefting of the oral cavity to the ear, or you can have a clefting along the side of the nose where the nasolacrimal groove never really finishes forming. As it works forward, getting towards 14 weeks, the face is starting to look very human, and the remaining portion of the nasofrontal process will be the strip of skin over the nose and also the philtrum. With the palate formation, we're going to look in a different plane, but it will have some of the same players, including that maxillary prominence and the medial nasal prominence, which is coming off the nasofrontal areas. As things progress, those maxillary prominences will fuse to the medial nasal prominence, and then there'll be an intermaxillary segment which will grow backwards to the level of the incisive canal. The incisive canal is the stopping point or the border between the primary palate and the secondary palate. So the primary palate is actually a very small component of the palate in general. Most of the malformations, if they're early in the process, will involve the primary palate. If they're late in the process, they may only divide the soft palate or even just a split uvula. Now, what do we want to know about the clefting of the lip and the clefting of the palate? Well, in red we'll see the lips and clefting, and then in the blue we'll see palate clefting. First of all, cleft lips can be either unilateral or bilateral, and they can be with or without a conjunctive cleft palate in association. They're relatively common, with 1 in 1,000 births having a clefting, and they happen in males more often than in females. They occur when there's a failure of the maxillary prominence to fuse with the merged medial nasal prominences. As is the case with palates, the classification will be in reference to that incisive fossa. So if it's anterior to the incisive fossa, it's a primary palatal defect. If it's posterior to the incisive canal, it's going to be a secondary palatal defect. Those happen a little less commonly, 1 in 2,500 births, and they will be more common in females. And I'm not sure that any of the reasons behind why this happens are actually known. Here we can look at some clefting issues. We have a before problem where we have a unilateral clefting of the lip, and it looks to have some clefting of the cavities as well. So what is this going to create? Well, it's going to create a failure for this infant to gain weight because they can't make a proper suction between the nipple and their oropharynx because of the nasal cavity always being open. So they definitely have feeding problems. Oftentimes they'll get milk into their nasal passages during feeding. They'll have malaligned or misaligned teeth. They'll oftentimes have poor growth habits, and the recurrent ear infections can be problematic for this group as well. Not to mention speech difficulties because of this palatal defect. If you're going to repair these issues, then it's best to do it at 6 or 9 months, and some of these need staged into 1 or 2 surgeries if the severity of the deformity is great. It's still a major issue in developing countries, and Doctors Without Borders or SMILE will go to some of these countries and try to do as many cleft palate repairs as they possibly can. Another first arch syndrome is going to be Pierre-Robin syndrome. Pierre-Robin syndrome has a primary mandibular hypoplasia, which actually causes the glossotosis because his jaw is so small. If the jaw is small, that means the tongue is relatively large, and a secondary effect of not being able to fit all the tongue in the oral cavity is that these kids will tend to have an obstructed palate growth, and that will leave a palatal clefting as well. So they'll oftentimes have a small jaw, a large tongue, which leads to obstructive development and is known as the clefting palate. With a DeGeorge anomaly, another developmental problem, there's an immunodeficiency disorder in which the thymus gland is going to be absent or underdeveloped. And again, this is maybe a result of faulty neural crest migration. The thing you want to remember about a DeGeorge syndrome is that there's a mnemonic to help you remember what it does called CATCH22. That means that there's going to be cardiac anomalies, abnormal faces, thymic hypoplasia, clefting of the palate, and hypocalcemia. And all of this happens on the 22nd chromosome. So there you can have CATCH22. The deletion on the long arm of the 22nd chromosome and the faulty migration of the neural crest are what will oftentimes lead to this. But there can be exposure to retinoids,